My name is Ryan Antiel. I'm Assistant Professor of Biomedical Ethics and a resident in the Department of General Surgery at the Mayo Clinic in Rochester, Minnesota. I'm joined here with co-author and mentor Dr. Frederick Hafferty, along with Dr. Darcy Reed, who's a professor of medicine at the Mayo Clinic, and Warren Kinghorn, who's professor of psychiatry at Duke University. We're co-authored an article titled Professionalism, Etiquette or Habitus, which will be coming out in an upcoming edition of the Mayo Clinic Proceedings. In our upcoming article in the Proceedings, we examine the topic of professionalism. Specifically, we have some concerns with the recent emphasis on behaviors above and beyond the internalization of virtue or character of a medical trainee. In this piece, we examine several arguments for a more behavioralist understanding of professionalism, specifically one that borrows from parts of medicine such as the intensive care unit a checklist approach to behaviors or deportment on one hand, while de-emphasizing the virtues and behaviors of the trainee on the other. In this way, we, the authors, have some concerns that a strictly behavioralist understanding of professionalism is able to sustain the particular behaviors that the profession wants its trainees to exhibit in a meaningful and long-term fashion without actually internalizing the virtues of the profession. In this article, we are arguing for a habitus, which is defined as a predisposition to act in a particular way. The trainee, analogous to the development of a technical skill, say in surgery, learning how to suture, to cut, to feel the tissue, and over time that particular trainee develops those skills such that she can one day practice on her own. Likewise, in terms of professionalism, the trainee, under the mentorship of physicians who are excellent at displaying professional virtues, begins to learn and become predisposed to act in that way, such that when they're in a new and novel situation, they are able to act professionally. So this is something that's not merely scripted, but becomes internalized such that it can manifest itself in new and unique ways. This concept really goes back to Aristotle and Thomas in terms of virtue development. Aristotle's concept of phronesis, or a practical wisdom, is very important here, where one develops the ability to discern in unique and challenging situations how they should go ahead and act. We believe very strongly that medicine is a moral enterprise, and despite the many forces of commodification and commercialization present today, ultimately it's still a moral enterprise. As the physician-philosopher Edmund Pellegrino emphasized over his career, all of us, physicians included, will one day find ourselves on a gurney. We'll be dependent, vulnerable, anxious, and at that moment when the physician enters into the room and says, "Can I help you?" we expect something. We want that individual to act in our very best interest and for no other interest. And so when a physician enters into that relationship with a patient, when they say, "Can I help you?" and step in to do so, they're professing something, they're promising something, they're declaring something, that is to help, to put the interests of the patient above their very own. And by separating behavior from that internalization, that motive for doing so could very much be problematic. The philosopher MacIntyre, in his definition of the virtues, really brings behavior and this internalization together. For MacIntyre, virtues are practices, particular practices that are embodied in a particular community. And medicine is one of those communities where the particular practices displayed over a course of time becomes ingrained in the trainee such that they too can act in a professional manner. And so we believe very strongly that these two ought not to be separated, but rather that they ought to be wed together, the behaviors as well as the character development.
The broader context for this article is medicine's modern-day professionalism movement, which dates back really to the mid to late 1980s. At that time, medical leaders began to express concerns that medicine was losing its professional identity, with a major threat being seen as the rise of commercial forces in medicine. Over time, and within particularly the medical education community, there were a variety of efforts to define medical professionalism, to measure it, and then in a range of activities to institutionalize professionalism within organized medicine via the creation of codes, charters, competencies, and a variety of curricula that now exist at virtually every medical school in the country. Part of the issue is this distinction between definitions and measurement, with a focus on measurement being largely driven by an emphasis on measurable behaviors, which are necessary to evaluate, but don't necessarily come close to an adequate definition of what it is. One of the challenges for medical education is whether or not educators identify themselves as helping to produce individuals who are going to act professionally, or whether they identify themselves as helping to produce individuals who are going to be professional. We argue for the latter approach, the being side of the picture, as being fundamentally different from the acting side of the picture. Not that you can totally separate the two, but the being is a much more fundamental state than a behavior-based approach.
One of the potential pitfalls of a strictly behavioralist understanding of professionalism is in terms of authenticity. When we strictly emphasize behaviors above and beyond the internalization of the professional virtues, there's the potential for the trainee to simply strive to look the part, to fake the behavior. And checklists are very amenable to this, for that particular trainee knows exactly what the evaluator wishes her or him to do, and can very much act in such a way while under observation. But what we're really interested in is behavior that's sustainable, and ultimately that which is authentic. And a truly authentic professional is one who can be trusted when no one is watching, when the observer with the checklist is no longer present, when one is tired, burnt out, it's 2 o'clock in the morning, and they encounter a patient. That's when the rubber meets the road. Strictly behavioralist approach to professionalism falls short in producing sustainable and authentic professional behavior.
And that's the challenge for medical education statement. It would be far easier to construct an education system that focuses on behaviors, and much more difficult to generate an educational system that targets virtue, character, and the authentic internalization of that. I think it's a fascinating ongoing discussion about how medicine is both similar to and distinct from other service occupations. What makes medicine different? And why should you care about a virtuous whatever versus a virtuous physician?
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.